up, future respiratory therapist? In this video, we're talking all about pulmonary vascular resistance. This is a tough subject. A lot of students, especially, they don't like hemodynamics, but we have to talk about it because you're going to have a question on it and you need to understand it. Let's dive in. All right, so as I stated, today we're talking all about pulmonary vascular resistance. This is shortened and abbreviated oftentimes to PVR. So if you ever see PVR, this is likely what they're talking about, especially when you're taking your board exams, okay? So PVR, pulmonary vascular resistance, what is it? Let's jump into it. Now, it's very important that anytime you're talking about anything cardiac monitoring or hemodynamic monitoring related, that you have to, I can't stress this enough, you have to understand normal blood flow through the heart. If I was to ask you right now, what comes directly after the left atrium? Which valve comes after the left atrium? You should be able to say mitral valve like that. And that's how important it is to understand, because if you get confused on this, you're like, I don't think I know that the lungs fall between the right ventricle and the left atrium, then that's where we need to start. Okay, so we're going to start there and just quickly review this. Now, the question is when you're looking at blood flow through the heart, the question is always, well, where does it start? Well, typically we think about it starting as blood flow coming back to the right atrium. And then it goes through the tricuspid valve and into the right ventricle. And then it goes through the pulmonary valve into the pulmonary artery. The pulmonary artery carries blood flow to the pulmonary capillaries. That's happening all throughout all of the lungs, okay? And then after gas exchange, blood flow returns from the pulmonary capillary network back to the left atrium through the pulmonary veins. Now, from the left atrium, we go through the mitral valve into the left ventricle, through the aortic valve, and then out through the aorta, where we go out for systemic circulation for tissue oxygenation to the rest of the body. From the body, it returns back, venous blood returns back through the superior and inferior vena cava and returns back to the right atrium, and it starts over from there. Now, in addition to understanding that, you also need to have a good understanding of what are we monitoring when we monitor cardiac values. When we're monitoring hemodynamics, what are we talking about? Well, there's four to five primary values that we monitor. And I know somebody's going to get me in the comments and say, oh, there's more than that. And that's fine. But here's the primary 4 to 5 that we monitor. The first thing we monitor is CVP. Now, CVP brings us back to the right atrium. Okay. From there, we monitor pulmonary artery pressure. Guess where that is? The pulmonary artery. We also monitor pulmonary capillary wedge pressure, which when you think pulmonary capillaries, you would say, okay, well, that's going to go right here. But it doesn't, because it's actually a reflection of left atrial pressure. So we say pulmonary capillary wedge pressure up here, and then we know that the left ventricle is responsible for blood pressure and cardiac output. Those are the 5. CVP, pulmonary artery pressure, pulmonary capillary wedge pressure, blood pressure, cardiac output. For the haters, cardiac index as well. Now, this video is all about pulmonary vascular resistance. So what we need to understand here is that not all of these values will help us in determining pulmonary vascular resistance. And so I want to talk specifically about that, okay? Because that's what the topic here is today. When we talk pulmonary vascular resistance, what we're talking about is the resistance of blood flow through the pulmonary vessels, okay, through the pulmonary capillaries. And honestly, it's a challenging concept. It's one that I struggled with when I was in school. and really honestly, just recently, really found a way to go, oh, that's what we're talking about. You see, as respiratory therapists, we're really good at understanding airway resistance. So if I talk about this endotracheal tube and I compare it to this endotracheal tube, we have a 9.0 and a 7.0. Everybody knows, oh, the 7.0 has a higher resistance. And we know that because it's more narrow. It's got a smaller diameter than the 9.0. Now we know that the flow going through this also matters. But if we wanted to look at how much resistance this tube created, what we would do is we would put a flow of gas through and we would measure the pressure difference from the beginning to the end, and then we would divide it by the flow of gas. And that would tell us the resistance of this airway. You see, when we talk about blood flow through the pulmonary capillaries, it's the same concept. If the vessels within the pulmonary units, the pulmonary capillaries, if they get smaller, if they go from a 9 to a 7, then resistance is now going to increase. Okay. And so it's the same thing. We just have to think about it in slightly different values and in terms. Gas moving versus fluid moving still follows the same principles. How big is the tube it's traveling through, and how fast is the material traveling through it? It's the same concept. You'll see that here in just a little bit when we break down the formula. So, but when we talk pulmonary vascular resistance, again, if we're talking about where do we start and where do we end, then we realize that this element comes out of it. What am I saying? I'm saying that systemic circulation comes out of the picture. Now, why does systemic come out of the picture? Because we're only focused on this element right here. What is the resistance of the pulmonary blood flow? You see, that's going to take us to a different image. So we get rid of this person, and now we see that this is all we're really talking about. Because if we want to know the resistance of the pulmonary blood flow, then we have to say, okay, well, where does that start? Well, it starts, remember, at the pulmonary artery. It starts right here. And where does that end? Well, it ends right here at the left atrium, which we remember is pulmonary capillary wedge pressure. Everything that happens between these two is going to cause an increase in resistance of pulmonary blood flow. Now, there's another important element I want to put in right here, and that is the word afterload, because you're going to hear this word. You're going to see this word afterload. And so you may say, okay, well, what effect does pulmonary vascular resistance have to do with afterload? Well, remember the definition of afterload is the resistance for which the ventricles have to push against to circulate blood flow through either the pulmonary system or the systemic system. Now, we're talking about the systemic system. So we're not talking about the left ventricle. We're talking about the right ventricle. And this should make sense because I think we all pretty much are able to say, COPD, chronic hypoxemia, cor pulmonale. Okay, but wait a second. Why does COPD have a correlation with cor pulmonale? Well, the answer to that is we understand that chronic hypoxemia leads to chronic hypoxemia. Okay? We understand that COPD leads to chronic hypoxemia, which leads to chronic pulmonary vasoconstriction, which leads to an increase in pulmonary vascular resistance, causing an increase of right ventricular afterload, which means the right ventricle has to work harder to perfuse and circulate blood through the pulmonary network, the pulmonary capillary network. That's why the right ventricle is oftentimes enlarged in this patient population. Now, other things that can cause an increase in your pulmonary vascular resistance are things that can cause any disease process that can cause alveolar hypoxia, things like pneumonia, congestive heart failure, atelectasis, ARDS. All of those things are going to cause regional alveolar hypoxia, and the body's natural response is to vasoconstrict. And so these pulmonary vessels will get smaller, which means the right ventricle has to work harder to push the blood flow through them. Why? Because those diseases lead to an increase in pulmonary vascular resistance. Now, that's just a handful of them. There's many more things that can cause an increase in your pulmonary vascular resistance. Anything that causes pulmonary hypertension, obstructive sleep apnea is highly associated with pulmonary hypertension. Of cardiovascular disease, such as mitral valve stenosis, will cause a backup and cause an increase in pulmonary vascular resistance. So that's just a few there. But I did want to mention those so you kind of have an understanding, like, well, what type of patients are we talking about here? Patients who are experiencing pulmonary vasoconstriction. Now, don't sleep on PEEP, because PEEP, especially excessively high levels of PEEP, can cause microcompression of the pulmonary capillaries. Microcompression will make them stretch and get smaller. As the alveoli stretch, it's going to compress those pulmonary capillaries and they're going to get smaller. And so you're going to see where that also will lead to a drop in blood pressure. Well, why does it lead to a drop in blood pressure? Because there's less blood flow getting through because of the increase in pulmonary vascular resistance. Okay, so keep those things in mind. Now, what we're talking about again here is from the pulmonary artery to the pulmonary capillary wedge pressure. What does this formula look like? Because you're going to have to do this formula, and it's a tough one to remember. But if you can understand what we're measuring, then it makes the formula make sense. Here's what the formula looks like. Pulmonary vascular resistance equals mean pulmonary artery pressure minus pulmonary capillary wedge pressure divided by cardiac output. Where have you seen this before? Oh, that's right. Airway resistance. Peak inspiratory pressure minus plateau divided by flow. The same formula, it's just giving you a pulmonary vascular resistance instead of airway resistance. So this makes sense, right? Pulmonary artery, pulmonary capillary wedge pressure. Why are those the values? Because this is where we start and this is where we end to assess all of the resistance between those two pressures. This is P1 minus P2. That's what resistance is. And then, of course, the final element here, cardiac output, which we know is going to be in liters per minute. Now, our normal value for this is about 0.25 to 1.6 millimeters per mercury per liter per minute. That's the units of measurement that we're talking about. Why? Because these are going to be in millimeters of mercury, and we're dividing it by liters per minute. And so these are the numbers. Now, Egan's does a really good job in their latest edition. I'll show you here. This is the 12th edition of Egan's. I believe the 13th is near coming out. I don't know if it's available yet or not, but this is the 12th edition on page 214. They give a really good example of this, okay? They work this problem out for you. And they say, like, okay, let's take a normal pulmonary artery pressure, which we know is about 10 to 20 millimeters of mercury for the mean. So let's just take, they use the number 16, so that's what I'll use. So 16 millimeters of mercury minus a normal pulmonary capillary wedge pressure, which normal is about 5 to 10. They use the number 8. And then we take cardiac output, and we know normal is somewhere between 4 to 8 liters per minute according to Egan's, and they use the number 5 here. So this is 16 minus 8 equals 8 divided by 5, and this equals 1.6. 1.6 what? 1.6 millimeters per mercury divided by liters per minute. This gives us a normal pulmonary vascular resistance. Okay, now if these numbers change, then that number is going to change and we're going to have different values here. But the thing is that something is going to cause these numbers to be out of normal range, and that's what we have to understand. Now, let me give you some exam tips because I want you to really understand what we're talking about here. Okay? When we're talking about this, there's so many formulas that you have to try to remember. But at the end of the day, if you can remember the concepts of the formulas before the actual formula, it will help you. And you won't need to actually even know the formula to probably find the right answer. And so what I want to show you here is we have two different tables, and this is what it's going to look like. You're going to get hemodynamic values that look like this on your board exams, and you're going to have to figure out for pulmonary vascular resistance, what values matter and what do I need to know? Well, remember, we're only talking about the pulmonary system. What comes first and what comes after it. Very important. Pulmonary artery to pulmonary capillary wedge pressure. Pulmonary artery pressure to pulmonary capillary wedge pressure. Those are the two values you need. And then as well as cardiac output, because you always have to know flow. Okay. So we go back to this exam tip. And what we see here is we don't need this if we're talking about PVR. What is the patient's PVR? We don't need CVP. We also don't need mean arterial pressure. No, spoiler alert, the next video is going to be about systemic vascular resistance. And guess what we're going to be talking about? The difference between MAP and CVP, because that's where the systemic vasculature happens. So, but for us, we just need these two values right here, and then we're going to divide it by this value here. So again, let's see this. We do, take our calculator, we do 15 minus 7 equals 8 divided by 6 equals a pulmonary vascular resistance. This one right here is 1.33. And remember, that's millimeters of mercury divided by liters per minute or per liter per minute. Okay. So 1.33 falls within the normal range of 0.25 to 1.6. Why? Because these are all normal values. We look at this example over here. We don't need CVP. We don't need mean arterial pressure. We only need pulmonary artery pressure, pulmonary capillary wedge pressure, and cardiac output. I want to show you something. When we do these numbers, here's what we get. 30 minus 6 divided by 5 equals 4.8. That's this one. Millimeters per mercury per liters per minute. Now, you clearly see we have an elevated pulmonary vascular resistance. But guess what? You could have told me that before you actually did the math, because let me clean this up for you. You see, look at the difference here. 15 minus 7 is 8. Look at the difference here. 24. See the difference? Just like airway resistance, if there's a large difference between your PIP and your plateau, you have an increase in airway resistance. If they are very close, like this, you do not have an airway resistance. Same thing here. Large difference equals increased PVR. Just by looking at the difference between these two. Same thing with end-tidal CO2. When you're calculating dead space, if there's a large difference between your arterial CO2 and your end-tidal CO2, then you're probably looking at a dead space problem. If they're very close, you do not have a dead space problem. In this situation, if these numbers are close, relatively within about 10 of each other, then you probably do not have an increase in your PVR. But if they get spread apart and you see a high pulmonary artery pressure and a low or a normal pulmonary capillary wedge pressure, or a big difference between them, that's what this means. If this pressure here, if this pressure is much greater than this pressure, then there's a lot of resistance happening in these regions, which is the pulmonary capillary network which is what we're talking about when we talk about pulmonary vascular resistance. I hope you found this helpful. Hey, do me a favor. In the video description below, there's going to be a link to this page right here. I want you to go sign up for my respiratory coach resources, my free resources class. It's completely free. You don't have to purchase the thing. You do have to register for it, but you do not have to. Doesn't cost you a penny. Go get into that. I have lots of stuff in there over waveforms, ICU checklist, all kinds of different resources, even a couple of quizzes related to some videos on YouTube. Go check that out. Have fun with that. If you're looking to pass your board exams, these two courses right here is the TMC Bootcamp and the CSE Bootcamp. They are there to aid you to pass that exam on the first attempt. Remember, it's all about clarity and confidence as you go into those exams. These two boot camps will provide you with that clarity and confidence that you're looking for. And then if you're looking for additional support in maybe pharmacology or maybe arterial blood gas interpretation, I have two other courses here that you, of course, can get into and purchase and work through those courses. And you can bundle these together at an insane discount, have access to all of them, so that you can be successful along your educational journey as you work towards becoming a registered respiratory therapist. And remember, at the end of the day, average is easy. Don't be it.